Hello, welcome back from lunch. I'm John Hooton from Mount Sinai, New York, and I'm going to be moderating this exciting next segment on cervical disc arthroplasty. I think that anyone who's been practicing 15 or 20 years remembers the excitement and the energy in the air when disc arthroplasty first became available. And then 10 years later, I think there was a widespread disappointment that it didn't make as big an impact in the average surgeon's practice as we thought. But I think that there is a change in the air now again, that we're understanding this technology better and understanding better how it might be applied. Now, Dr. Amir Abtahi for the relevance of cervical foraminotomy to disc arthroplasty.
Thank you very much, John. No disclosures. We're going to be discussing the relevance of posterior cervical foraminotomy in the treatment or revision in the setting of cervical disc replacement. And I thought this would be a good opportunity, since that's a rather specific question, just to sort of go over the surgical treatment options for cervical radiculopathy. And there are three main options: anterior cervical discectomy infusion, cervical disc replacement, and posterior cervical foraminotomy. All of them are excellent in their own regards. They're tools in our toolbox and things that we should deploy on a selective basis depending on the patient and the circumstances. Advantages of anterior cervical discectomy infusion are that you can obtain a direct and an indirect decompression through graft height. When we get a solid arthrodesis, it's a durable treatment, at least at the index level. Its disadvantages, the main disadvantages are the anterior approach. We have talks, I'm sure, coming later this weekend on dysphagia and dysphonia. Loss of motion leading to adjacent segment degeneration and disease has just been covered. And pseudoarthrosis. And actually, in the IDE trials, this turned out to be a sort of unexpected advantage of disc replacement over anterior cervical discectomy infusion, is that you don't have to deal with this problem of pseudoarthrosis. Relative indications are patients with kyphotic alignment or segmental instability, people who aren't candidates for other operations. Contraindications would be any contraindication to an anterior approach. Cervical disc replacement is a motion-preserving procedure. It certainly may and likely does protect against adjacent segment disease. Similar disadvantages to ACDF, the anterior approach. Two that are relatively specific to it, however, are the problem of device-related complications and failures, and the problem, because we're maintaining motion, of recurrence of stenosis at the index level. So, indications are similar to that with ACDF when motion preservation is desired. Contraindications are when the anterior approach is contraindicated: severe spondylosis, disc degeneration, facet arthropathy, osteoporosis when the bone and the end plates will not support an implant, and then kyphotic alignment and segmental instability. And then finally, posterior cervical foraminotomy. So this may, in fact, be the motion-preserving procedure, and likely is. It's the OG. Protects against adjacent segment degeneration. The rate is 0.7 to 0.9% per year to 2.9 versus 2.9% per year for ACDF. It certainly has a favorable complication profile related to the lack of need for an anterior approach, and is less costly. Disadvantages include recurrence of stenosis at the index level with longer-term follow-up and the question of whether iatrogenic instability may exist. So certainly we're using it in cases of cervical radiculopathy when the anterior approach is contraindicated. Contraindications include kyphotic alignment and segmental instability. Any central pathology would also be a contraindication. So there's two main questions that this talk is aimed to answer, and that is posterior cervical foraminotomy an appropriate surgical option for the treatment of persistent or recurrent radiculopathy after cervical disc replacement? And the other side of that coin, is cervical disc replacement a safe and effective option for the treatment of persistent or recurrent radicular symptoms after foraminotomy? Just talk real quickly through the technique. Patient's positioned prone in slight flexion. You can use a Mayfield positioned in slight flexion, or you can place your Gardner-Wells tongue slightly posteriorly, which helps with creating a bit of flexion. You can create a midline or a paramedian approach, depending on whether you're choosing a mini open or MIS tubular approach. We expose the medial 50% of the facet joint. Localizing radiographs are obtained, and you can bring a tube into position if you're using one. This is your visualization. You want to visualize this Y point. You're visualizing the most lateral aspect of the lamina where it meets the lateral mass, and the facet joints at facet joint at that level. This is sort of the shape that I aim for a lot of my foraminotomies. I narrow it a bit as I move laterally. The first thing you do is you resect this inferior portion of the inferior facet of the level above. You should be looking at this point. This is sort of the contour of what the superior articulated facet that you'd be looking at once that bone is removed. You burr that away, being careful to avoid the pedicles. This is sort of, this green triangle here is an idea of the resection that you are creating. And this model's a little bit misleading because it's rolled up about 45 degrees, but this is the bone you're removing that creates decompression of the nerve root. I'd use a mini open approach. I use a Williams retractor for that, and I think that's a perfectly reasonable option. If you're a real masochist, you can do an endoscopic posterior cervical foraminotomy. It's a very similar approach. My partner, Ray Gardaki, was nice enough to loan me this video. You can see the exiting nerve root there. Disc is right below it. He's pulling the nerve root up, and you're seeing disc material. It's the same technique you'd be using if you did this open or tubular to do a discectomy if you needed to. Postoperatively, do outpatient surgery or 23-hour observation. I use a soft collar for the first couple of weeks just for comfort. Gentle range of motion. Exercises can start almost immediately. So all three of these approaches have similar pain relief and efficacy. 70 to 97% of patients get relief. MIS surgery versus open has a shorter hospitalization, less pain and less blood loss, but outcomes are otherwise equivalent. There are a few factors that are associated with worse outcomes following posterior cervical foraminotomy. One would be high amounts of pre-op neck pain, older age, or patients that are severely spondylotic or with severe facet arthropathy, and then patients with multiple levels of foraminal stenosis. So this is just a really nice slide from a review article showing real high rates of improvement following posterior cervical foraminotomy. We talked about the adjacent segment disease. There is this problem of same segment disease, and at 10 years in this paper, that was about 5%. This is another paper looking at 151 cases of foraminotomy. Overall reoperation 10% at 2.5 years. 6.5 of those were at the same level, really low level of adjacent segment problems. This is just, I'll just go through this real fast. We probably have the lowest rate of adjacent segment disease with foraminotomy. This is a plug for the foraminotomy. Whenever you're thinking about disc replacement, you should also be thinking about foraminotomy in appropriate clinical scenarios. Complications are low, 3.3% in this study. Infections seem to be the most common complication. Nerve injury and a few dural tears are a possibility given the posterior approach. Patients do better with soft disc subtypes compared with patients with bony osteophytes. Same data, wound complications are a little higher in patients after foraminotomy, as you might expect, dysphonia higher after anterior cervical approaches. Revision rates were the same in this study. as they were here, although sort of trending towards significance. I think the IDE trials showed pretty decisively that, at least in that study, that cervical discs had lower reoperation rate. As one would expect, pseudoarthrosis is a problem in ACDFs, and recurrent symptoms are more of a problem in posterior cervical foraminotomies. I'll skip that slide. As we discussed, reoperation is probably lower for cervical disc based on the IDE studies. You deal with the problem of device-related complications and recurrent stenosis. I will mention this briefly, and that is that I see with a lot of these devices, as well as with some of the titanium interbody implants, that there's a high amount of metal artifact. It makes working up problems when they occur rather difficult. In most patients, I end up getting myelograms for better visualization. This is a study out of Rush that was put out a couple of years ago. This is a really nice summary of failures after disc replacement, the 4.1 to 4.8% failure rate. They classified them into several categories. The most common is just recurrent stenosis rather than any mechanical complications. And they actually found that the keeled implants had a higher rate of stenosis and actually sort of overall problems than the non-keeled implants. So revision strategies for failed cervical disc depends on the mode of failure. For stenosis, we have posterior cervical foraminotomy as an option. This should be reserved for patients with well-fixed, well-aligned implants. These sort of scenarios with bone loss and subsidence and device migration and malalignment, these are not people who should get foraminotomies. This is a really nice summary from that paper. It goes over all the other sort of modes of failure and revision options. Anterior cervical conversion to an ACDF is an option, as is posterior cervical fusion. Some people will revise to another disc arthroplasty implant. The main indication for me to do that, I've never done it, would be an implant that was malpositioned during surgery and recognized immediately, revised to another implant. Otherwise, I'd be likely converting them to a fusion. Okay. So now to the final question. I know I'm running over a little bit on time. The surgical treatments for cervical radiculopathy in the setting of disc replacement, we have very limited data with any long-term follow-up. Most of it's biomechanical. We know that resecting more than 50% of the facet joint from some older studies creates some more instability. There are 2 biomechanical studies that have been published on this. This is looking at the different groups aren't necessarily important, but the summary of this study was that the addition of unilateral or even bilateral foraminotomies did not lead to instability as long as the resection was limited to less than 50% of the facet joint. Same thing here. The takeaway from this study was that if you do a full laminectomy, that actually can create some instability. That's the sort of upper graft displacement, the load displacement curve that you're seeing, and that should be avoided. Skip over these. This is the only study with any clinical data, very small. This is 15 patients who had a previous surgery. 6 of 15 of those had a posterior cervical foraminotomy, and there was 24-month follow-up on these patients. These are patients that ended up getting arthroplasties. None of those cases had hypermobility or instability. There were no formal outcome measures collected. So the summary is that posterior cervical foraminotomy is an appropriate option for the treatment of persistent or recurrent radicular symptoms after cervical disc replacement in patients without mechanical failure. Disc replacement is an appropriate option for treatment of persistent or recurrent radicular symptoms after posterior cervical foraminotomy. There's no evidence that there would be any instability there. Bilateral foraminotomies are okay. Laminectomy would not be, but foraminotomy should be kept to less than 50% of the facet joint.
Okay, I think we have time for a couple of questions. You can come up to the mics while we're waiting for the audience. I could ask any of the panelists. few people need a surgery because they have a perfect disc segment. And I think that there are some authors who have talked about more spondylosis being tolerable. And I want to know what your attitudes were about doing disc replacement on a patient with some degree of spondylosis and where you would draw the line.
I can start, John. I think it's an important point you bring up. I think the original studies talked about loss of disc height to a certain extent being a relative contraindication. I'll say in my own practice, as I've gotten better at doing disc replacements and I feel more comfortable getting like really good releases, my primary contraindication is if there's facet arthropathy. But disc height and uncovertebral arthritis, I feel better about doing an arthroplasty, but I do that operation differently than I would for a soft disc herniation because I do really spend a lot of time sort of getting out with a kerrison and sort of biting out and really making sure on an AP radiograph that we're restoring the uncovertebral height. But yeah, I'm curious to hear what others think.
Yeah, for me, disc replacement is a disease of soft disc herniations. And so I really tend to shy away from those spondylotic patients in their 50s, 60s, and 70s. I really do, because I think they go on to have higher failure rates, and it seems to be, need fusions, need revisions, and so forth. So I shy very much away from that spondylotic patient to a great degree, certainly somebody with facet arthropathy.
Any other thoughts?
I agree with that. I tend to steer patients away who are in their 50s, 60s, 70s with a lot of facet arthropathy from arthroplasty. Now, some of them still want an arthroplasty, and they don't really care what you think. They have read on the internet that it's going to be the next greatest thing since sliced bread. They're getting an arthroplasty one way or another. I will say that I went to Taipei as visiting professor, and they were basically putting an arthroplasty in everyone who walked in through the door, and they even have some people with OPLL, mild OPLL, they're putting in arthroplasties. And I thought, this is weird, this is not going to turn out well. But actually, they published their results in JNS Spine. It actually turns out okay. It's not like the patients are, having terrible revision rates. It's not as good as someone who's young with a soft disc, which is my primary indication for doing it. But it wasn't terrible, even if they put it in these spondylotic people.
Shiraz or Praveen, do you, if you have a patient that's very spondylotic, which sort of implants do you use? Does it influence your implant choice?
Yeah, for me, I primarily use a keeled implant just because I like the stability and being able to tell people, that I'm comfortable with them getting back to things. The spondylosis probably has less impact, but sometimes if there's a really collapsed disc where I'm worried, then I'll lean towards one of the devices. Simplify has like the kind of smallest option available that we could still get in. So that's a small consideration.
From the front.
Okay. Sang Lee from Johns Hopkins, Baltimore, Maryland. I got a comment and question about the foraminotomy with the disc arthroplasty topic. So I totally agree with that. Prior foraminotomy is okay with the disc arthroplasty because a few points. Even we think we remove the 50%, if you check the CT scan, it's much smaller. And also, the facet joint is growing back over time. It's in the literature. It's up to 30-40%. I think that's okay with the stabilizing facet. But I think at that point should be tailored because some posterior pathology could be a contraindication of disc arthroplasty. That's the comment. But question to the panel. So, what about, I don't have any experience with foraminotomy after disc arthroplasty. So I'm going to ask questions, experience, any thought?
I think, based on the work we did researching this, I think it is a perfectly viable option. We don't know what the clinical outcomes are. There's really not any existing data. It'd be a great paper to be here at CSRS in the next couple of years. But I think the most important thing, and the thing that I tell everybody, is you just want to make sure you're not sticking your head in the mud with some other problem with your disc implant, mechanical complication, device-related complication that you're ignoring and doing a foraminotomy. You could certainly make that problem worse.
Are we still worried about debris and longevity of the implants. I have heard very few people speaking about that lately.
I'm not so much worried about it. I think that's much more an issue of lumbar arthroplasty and large joint arthroplasty than it is for cervical. The cervical motion-bearing surface is so infinitesimally smaller than those other ones. I have not seen an issue with wear debris and all kinds of foreign body reactions. Or I'll say I have seen it maybe twice in a decade.
Yeah, I agree with Praveen. I think a well-done arthroplasty, you probably don't have that issue. You know, I think if the implants were sized too small or there was like too much end plate removed, there was this issue of like HO or subsidence and probably early wear. There have been some reports on, you know, one of the implants in particular having some issues with wear rate, but I think it's debatable. I think most of it is, it just comes, like, if you're doing an arthroplasty, it is a different operation. And I think the point that Praveen made in the first talk where, you know, unfortunately, we get paid less to do a harder operation that, you know, can go bad in a lot of ways is unfortunate.
It's the elephant in the room.
Yeah.
The front.
Drew Bednar from McMaster University in Ontario, Canada. I came up to ask my question just before you started that discussion, and it's a nice synchronicity. I have experience with about 150 cervical arthroplasties before the Canadian Budget Police caught up to me and shut me down. But they were very early in the release, so they're late. We have lots of 2-year outcomes data that's pretty good, and I followed my people for that year or so and said goodbye. I've had several come back with really problematic late ankyloses in the 8 to 10 year range, and they're ankylosing in flexion when their baseline alignments were very, very good, which I think I can explain, but it's a little flaky. I'd like to ask the panel if they have any experience with this, because it's a really thorny late problem to deal with. The revisions have just been awful.
I'll take a shot at that. The ones that I've seen ankylose have ankylosed in a neutral, basically straight, you know, neck position. I haven't seen them ankylose in a kyphotic position. Maybe once or twice in a long time that I've seen that. So I don't know if that's related to the, you know, what you know, product you used for your arthroplasty, but for the most part, when they ankylose, they seem to be, for me, ankylosing neutrally.
Are you seeing early ankyloses or later ones?
No, I usually see it, if I see it somewhere around 5 years. Because I used to follow them all. You know, when I first did them, I was in one of these, you know, US FDA trials. So we followed everybody, and we were really, really, you know, specific to go find them and track them down. In the first 2 years, it really didn't happen. It was, you know, between the 5 and the 10 year mark that I started seeing some of this stuff. So, but they basically turned to an ACDF in neutral.
Thank you.
Front.
Hey there, Pat McNulty. Can you make a couple more comments on the issue of third particle debris? Because my simple concerns are, you've got Scott Blumenthal did a little presentation with revision TDRs, and it seemed like the design with the M6, which has that polyethylene kind of annulus, seemed to have a higher incidence of osteolysis, and that's kind of a different mechanism for third body wear than the traditional poly on metal. And then also make a comment in regards to the simplified disc, which has that ceramic core on peak as its weight-bearing surface. So maybe expand the comments on that, because those are a little different as far as mechanism and basic design.
I have not used the M6, so I can't really comment on that. Shiraz, I don't know.
Yeah, so I agree. I mean, it's very debatable. So this is like, you know, just my opinion. But yeah, I agree. I mean, I think the strands of polyethylene, which are sort of in the core of M6, it has potential to have debris. Now, there are some people that use it and they say it is absolutely not the case. But the ones that I have seen in recent years, especially over the last 2 years, that have come into my office with like early issues of debris, especially where like you could see osteolysis around the end plates, have all been M6. And I don't know if that's just bad luck or if that is a function of the implant. But yeah, I don't use the implant personally. But again, it's just my opinion.
I think it's it's my opinion as well. And so, not to throw anyone under the bus or anything like that, but it does seem that the ones that I've revised have that osteolysis that is at the superjacent end plate. And it is, I assume, from wear debris.
Yeah, so I'm not familiar with the details of the testing protocols, but obviously it'd be ideal because you got some basic differences in implant design to somehow quantify that third body debris. And, just empirically thinking about the M6, there's a lot more interface, a lot more shearing going on. And I think TBI's done a lot of those studies, and it seems to be an issue with that. But again, the Simplify for me, one of the biggest deterrents for me to do a disc replacement is simply imaging. But now with the Simplify, it's got PEEK with the plasma spray titanium and a ceramic core. The imaging's great. So again, but that's a new kind of design. I've never heard of a ceramic on PEEK as an arthroplasty design. Any comments on that?
I've used Simplify, and I agree. The imaging qualities are really, really good if you need to get a postoperative MRI. But I will say I mostly use Prestige LP, which is a metal-on-metal disc. I mean, the MRI protocols now, the one that we use at our hospital is called the Maverick protocol, which is a metal subtraction protocol, and you can get fantastic. I never have had to, in at least the last 3 years now that we've been using Maverick, have had to get a CT myelogram on a patient due to metal issues. And it really came from large joint arthroplasty where they needed to get MRIs to kind of look around. And so then we started using those for our spine cases as well. And the metal subtraction MRIs are really, really good regardless of arthroplasty type. It still, doesn't compare to obviously the Simplify, which that's like its big advantage. But you can get good MRIs with certain MRI protocols with other arthroplasties as well.
So one more simple point, as you perhaps push more into a spondylitic patient that still has reasonable motion, obviously recurrence at the index level is more of a concern, correct? So the other issue is how's the CT imaging? Because even CT can have artifact as well. And again, it's just, with index level concern of recurrent of disease, the imaging's a big deal for me, so. Comments?
I think with, the two that I use the most frequently is Prestige LP and Simplify. The imaging characteristics, CT and MRI, are manageable with current imaging protocols. I think there are differences in some of these cast more shadow artifact than others. And I think with those two, the Simplify is relatively new, so I don't know what its wear debris issues are going to be 5-10 years down the road. The Prestige LP really didn't have that when we looked at it long-term in 7 years follow-up.
Thank you to all the panelists. That was a great session.